Hello, everyone, and welcome to the Cannabis Crossroads webinar series. My name is Dina Gaid, and I'm a postdoctoral fellow with the Cannabis Health Evaluation and Research Partnership Team, or SHERP. We are a multidisciplinary team based at Memorial University with investigators in pharmacy, medicine, education, and psychology, and a wide range of external stakeholders on our advisory panels. We will begin today's event with a land acknowledgement. We respectfully acknowledge the territory in which we gather as the ancestral homelands of Biphasic, and the island of Newfoundland as an ancestral homeland of Mi'kmaq and Biphasic. We would like also to recognize the Inuit of Nunavut and the Nunavut, and the Inuit of Sinon, and their ancestors as the original people of Labrador. We strive for respectful relationship with all the people of this province as we search for collective healing and true reconciliation and honor this beautiful land together. Today, given that we are speaking to the medical uses of cannabis, we would like also to acknowledge patients and those who use cannabis for medical purposes as knowledge keepers. While research evidence on the uses of cannabis for medical purposes is still developing, we recognize that cannabis has been used for many years for several medical indications, and there is much to be learned from patient experiences. Please welcome our facilitators for today, Christina George. Christina works as an engagement planner with the Public Engagement and Planning Division with the Government of Newfoundland and Labrador, and our partners with CHIRP in the Provincial Cannabis Policy Evaluation. She will be supported by Nina Mitchell-Moore, also from the Office of Public Engagement and Planning. Now I'll pass the mic to Christina to run through housekeeping items and introduce the panel. Welcome, Christina.
Thank you, Dina. So I'm Christina, and I'm joined by my colleague Nina, so it's a pleasure to be here today. I want to thank you all for joining us for our discussion on information about medical cannabis. The CHIRP team has been examining cannabis policy for the past couple of years. When this started, they looked to the public and they looked to the community stakeholders to identify priorities that mattered to our community through a formal needs assessment process. While this supported shaping the direction for our research, it was recognized that there was a big need for public education. There's still a lack of understanding and misinformation circulating about cannabis. So this Cannabis Crossroads webinar series is meant to help address some of that need. Today, this is our final of 4 webinars in this series. Our panel of experts will be discussing current evidence around medical cannabis use, how we can support patient populations with respect to cannabis, and how patients can access medical cannabis. Before I begin, I'd like to share a few housekeeping notes. A Q&A will follow the presentations. With regards to questions, our panelists will address questions submitted through the Q&A function. We will not be offering the option to unmute today to ask the questions, so you may ask questions at any time, and they will be addressed towards the end of the session. Dr. Jennifer Donnan will be monitoring the Q&A. Please try to keep your questions short, and I encourage you to post your questions as soon as possible, and please not wait until the last minute. One note about content, a reminder that while we are discussing general concepts about information on medical cannabis use, our panelists are unable to provide individualized medical advice. So please keep this in mind when you're posing your questions. This session is being recorded and will be available to view online. Links will be available on the CHIRP website and will be shared through CHIRP social media channels as well. We also encourage you to use the hashtag #CannabisCrossroads if you choose to tweet about our presentation or our discussion today. And finally, CHIRP has received accreditation from the Newfoundland Labrador Pharmacy Board. And you can see the social media channels on the slide in front of you. So it's my pleasure today to introduce our 3 panelists. Isha Randhawa is a pharmacist and co-owner of 2 non-medical cannabis stores in British Columbia. Dr. Alia Norman, who is the lead physician at the Cannabis Clinic here in St. John's. And Emily Wadden is a social worker who works in harm reduction here in St. John's. So CHIRP is delighted to bring together perspectives and insights from 3 different healthcare disciplines today. We believe this will enrich our discussion today and help shed more light on how patients navigate through the healthcare system and the barriers they may face when seeking access to cannabis. So our first speaker today will be Isha Randhawa. So I'll briefly introduce her. Isha is a pharmacist and pharmacy manager and co-owns 2 recreational cannabis stores in British Columbia. Prior to cannabis legalization in Canada, she began studying the use of cannabis for medical ailments, particularly for the geriatric community. In her pharmacy, Isha established a welcoming environment, ensuring her patients felt comfortable discussing any non-medical substances they might be using. This open dialogue provided the foundation upon which the use of cannabis for medical purposes could be discussed in a safe and judgment-free manner. By actively participating in both medical and non-medical branches of cannabis, Isha has recognized that there are barriers to legal access for both medical and recreational cannabis users. She hopes to work towards bridging the gaps which exist in our current systems. Welcome, Isha, and I'll now pass the virtual mic over to you.
Hi, good morning, everybody. I will go ahead and share my deck here. Great, good morning. So welcome to Medical Cannabis from a pharmacist perspective. Before we get started, I would like to point out that I have no real or potential conflicts of interest to disclose today. A little bit about me. My name is Isha Randhawa, and I graduated with my Bachelor of Science in Biology, as well as my Bachelor of Science in Pharmaceutical Sciences from UBC in Vancouver. I am currently a practicing pharmacist and pharmacy manager at Rexall in Penticton, BC. My main patient population that I work with are geriatric patients with complex medical histories. I also own 2 recreational cannabis stores called Greenlight Cannabis in the Okanagan Valley. So today I'm hoping that after my presentation, you'll be able to understand the current available prescription cannabis options, a little bit about cannabis math, monitoring and managing patients who use medical cannabis, and how to access medical cannabis. I also want to talk about understanding the gaps to accessing this medical cannabis and barriers that both patients and pharmacists face. So to get started, there are 3 main drugs and 3 main routes. THC and CBD are phytocannabinoids found in the cannabis plant. There are hundreds of more cannabinoids, but these 2 are the most studied for the potential health benefits and implications. THC is a partial agonist at the CB1 and CB2 receptors. CB1 receptors can be found on nerve cells and CB2 receptors on immune cells. And this is the portion that is psychoactive. CBD can oppose the action of THC and make side effects a little bit more tolerable. However, the mechanism of CBD is not well understood at this point. It's also the non-psychoactive component. Finally, we have Nabilone, which is a full agonist at the CB1 and CB2 receptors. It mimics THC, but has a longer half-life than THC. The main routes of consumption include inhaled cannabis, so dried flower, pre-rolls, vapes, oral ingestion through caps, oils, edibles, and beverages. And there's also topical and transdermal options through creams, body oils, and bath bombs. So just getting into prescription cannabis to start. We have 3 major players when it comes to prescription cannabis. The first being Nabilone, which is a synthetic THC analog, and it's available in capsules. Next up, we have NABIXIMOL, also known as Sativex, and this is a full spectrum sublingual spray. Finally, we have CANNABIDIOL, also known as Epidiolex, and it is 98 to 99% CBD oil. So the indications for Nabilone includes severe nausea, vomiting from cancer chemotherapy, and it can also be used off-label for anorexia, palliative pain, and neuropathic pain. Prescription cannabis is easier to dose because we do it like all other medications. It's prescribed and it has a definite dosing regimen. Usually we start patients at 0.25 milligrams to half milligram at bedtime. And then the usual average dosing is 1 to 2 milligrams once to twice daily. The average cost for Nabilone per day is $3.60, but it's also covered by the provincial plan in BC and also by private insurers. If a patient wanted to find something similar in a retail store, it'd probably cost about $2.40 a day. Moving on to NABIXIMOL or Sativex. Sativex is an extracted THC CBD oil from the cannabis sativa plant, and it's indicated for use in cancer pain and MS neuropathic pain and spasticity. A couple slides ago, I said that this was a full spectrum THC and CBD oil, and what I mean by that is that they were able to preserve the unique cannabinoid and terpene profile from the cannabis plant variety that they used to make it, and this enhances the therapeutic effects of Sativex. Sativex is essentially a 1-to-1 ratio of THC and CBD, so you're getting 2.7 milligrams THC and 2.5 milligrams of CBD per spray. Patients normally start at 1 spray sublingually at bedtime, and usual dosing is 1 spray every 4 hours, up to a maximum of 16 sprays per day. Patients should be advised that they should allow at least 15 minutes in between sprays when they're using it. And something to note is that Sativex does contain alcohol, peppermint flavor, and is not very palatable. Doctors do prescribe Sativex, but often patients don't pick it up because of how expensive it is. It's about $32 a day. A 10 ml bottle ends up being upwards of $300. So it is quite expensive. There are similar options on the retail market that cost patients about $5.60 a day. And Sativex is not normally covered by private insurance or provincial plans. Finally, we have Epidiolex. Epidiolex is not currently available in Canada, but it is available in the US. It is 98 to 99% pure extracted CBD oil. Normal indications for this are seizures associated with Lennox-Gastaut syndrome or Dravet syndrome for patients aged 2 and up. Normal dosing is 2.5 to 10 milligrams per kilogram per dose twice a day. It should be noticed that while Epidiolex doses are high for seizures, cannabis extracts with minimal THC are rarely dosed above 80 milligrams as their total dose for most indications other than seizures. This one also contains alcohol, sesame oil, and strawberry flavor. And this one is dosed 2.5 milligrams to 10 milligrams per dose twice daily. And as you can see, this one is quite expensive at $105 per day, with a retail cost being approximately 32 Canadian dollars per day. So you could see how this one might be a barrier for patients. So just a general comparison of how much things cost from a prescription cannabis perspective, medical cannabis perspective, and a retail cannabis store perspective. The capsules, when comparing Nabilone to other options, are about the same, and Nabilone ends up being covered, so it's fairly cost effective. And moving on to 1-to-1 spray, Sativex is significantly more expensive than what can be found in the medical cannabis market or in a retail cannabis store. I'd just like to note that the comparison that I found in the medical cannabis market isn't actually a sublingual spray, but it is still a 1-to-1 full spectrum oil that's available. And finally, in that third column there, the CBD oils, that the most expensive one is the Epidiolex. and that's in US dollars. So the medical cannabis and retail store cannabis options are significantly cheaper than that. Now moving on to medical cannabis specifically. So medical cannabis is easy to dose. However, prescription cannabis is easy to dose, but medical cannabis is a little bit more complicated, and this is because of something called the entourage effect. Now, the entourage effect is the efficacy of cannabinoids is increased or the side effects decreased when used in combination with terpenes. And this also states that there is a highly synergistic relationship between the different cannabinoids, terpenes, and other compounds found in the plant when they're all combined together. Terpenes are minor medical components that are not cannabinoids, and they give cannabis and other plants their smell and taste. Normal everyday things we find terpenes in are tea and essential oils. The difference in strains of cannabis plants also depend on this. So indicas are generally sedating and more calming, whereas sativa strains are more activating and have more intense sensory alterations. So the general hypothesis is that a substance with low THC but high terpenes can lead to more of a therapeutic benefit and less side effects. When it comes to dosing medical cannabis, the general rule of thumb is start low and go slow. So because of the entourage effect, it is challenging to find a definite dosing regimen. Dried cannabis and vapes are normally measured in milligrams per gram or percentages. So if you see a package and it says 100 milligrams per gram, that is equivalent to 10% THC. Oils are normally measured in milligrams per milliliter and is a little bit more straightforward. According to Health Canada and the WHO, the average joint is between a half gram to a full gram, with THC ranging between 1 to 30% and CBD ranging 0 to 24%. It is important to keep in mind that about 50% of this content is lost due to combustion once the joint is lit. So if we wanted to know how much THC would be in a half gram joint, we would take the half gram joint, multiply it by 10% in this example, and 50% lost to combustion, so the entire joint would contain 25 milligrams of THC. Now, we wouldn't ask a patient to smoke the whole thing right away. We would say to take 1 to 2 puffs to start, wait approximately 30 minutes and to feel the effect, and slowly increase over time. When it comes to ingestible medical cannabis options, we usually recommend that patients start no more than 2.5 milligrams of THC, and again, start low and go slow, so they can slowly increase their dosing over time. We usually recommend 2 to 3 days. When it comes to the Health Canada forms that prescribers have to fill out in terms of accessing medical cannabis, there is a portion in there where the prescriber has to indicate the dried cannabis equivalency. So even if a prescriber is recommending an edible or some sort of concentrate, they have to write it as a dried cannabis equivalency. So I just wanted to identify generally what that would be. So 5 grams of fresh bud and leaves would be equivalent to 1 gram of dried cannabis. 15 grams of edibles would be 1 gram of dried cannabis. 70 grams of beverages, 0.25 grams of vape, hash, shatter, other concentrates, that would be 1 gram of dried cannabis. And finally, 1 seed that a person might plant is 1 gram of dried cannabis. So it's a little bit confusing because the prescriber has to be aware of what the equivalency would be. Some LPs differ from this a little bit, but it's all listed on their packaging, exactly how much dried cannabis equivalency there is. The maximum a prescriber can give is 5 grams of dried equivalency per day. So absolute side effects with medical cannabis are still undefined. They are heavily dose dependent. They depend on the route of consumption, the varying potencies, and the ratio of THC to CBD, as well as the patient population that might be consuming cannabis. So Normal side effects, or the regular side effects that we see, are CNS depression, dizziness, confusion, impaired motor function, dry mouth, short-term memory loss, increased heart rate, and orthostatic hypertension. A lot of these side effects are mostly seen with THC. For those who are consuming cannabis through smoking or vaping, they might experience throat irritation, coughing, and respiratory issues such as pneumonia, COPD, and lung cancer. For THC specifically, patients might experience long-term anxiety, paranoia, euphoria. It may unmask schizophrenia in patients who are predisposed. It might impair memory, increase appetite, cause driving impairment, and red eyes. And while CBD may not have many side effects for the most part, pediatric trials have found patients to have nausea and vomiting, aggression, anger, somnolence, irritability, decreased appetite, diarrhea, and altered liver enzymes. Overdose with cannabis is possible, but does not result in fatalities. Interactions with medical cannabis and other medications. THC can be sedating. So when taken with other sedating substances such as alcohol, benzodiazepines, and opioids, you can have additive CNS depression effects. Medical cannabis also involves the cytochrome P450 enzyme system, so there may be significant interactions through that. Smoked cannabis may act as a CYP1A2 inducer, which may lead to decreased concentrations of warfarin, caffeine, and TCAs. Most CBD drug interactions are clinically insignificant. However, CBD may be a CYP2C19 inhibitor, and what this can do is it can increase clobazam and citalopram, as well as decrease clopidogrel. So for patients who are using high-dose CBD, this can significantly increase the serum concentrations of clobazam as well. THC and CBD are both 2C9 and 3A4 substrates. So inhibitors of these CYP enzymes will increase the serum concentrations of THC and CBD, and this can lead to undesirable side effects. So these interactions would include fluoxetine, PPIs, macrolides, and grapefruit juice. CYP2C9 and 3A4 inducers can decrease the serum concentration of THC and CBD, thereby making them therapeutically ineffective, and common interactions are carbamazepine, rifampicin, phenytoin, and St. John's wort. So again, absolute contraindications are yet to be determined apart from hypersensitivity and driving while impaired. The rest of these contraindications are highly recommended based on the evidence that we have right now. This includes uncontrolled hypertension and arrhythmia, pregnancy and lactation, history of substance abuse, and unstable mania, depression, and schizophrenia. For patients who are under the age of 25 or have a history of substance abuse, we can assess the risk-benefit for these patients and still prescribe medical cannabis for them. For pregnancy and lactation, this is a topic that comes up regularly in both my recreational store as well as the pharmacy. And women that were cannabis consumers prior to conception usually feel pretty comfortable taking cannabis while pregnant. They use it for things like as an antiemetic and as well for pain. And then women who weren't cannabis users prior to conception are often curious about topical CBD options to help manage some of their pain. So these are questions that do come up, and there's not a lot of great evidence to suggest that it would be safe for patients to take. There's also not a lot of evidence to suggest that these topicals will be harmful either. So miscarriage comes up because we've seen that high levels of anandamide, which is an endogenous cannabinoid, has been linked to increased incidences of miscarriages. We do know that THC crosses the placenta, so it's okay to extrapolate that miscarriage might happen due to this. It may also cause preterm and stillbirth, low birth weight, negative neurodevelopment over long periods of time, and THC is also excreted in breast milk. THC can also decrease sperm count and the quality of sperm, and this is because CB1 receptors are found on germ cells and CB2 receptors on Sertoli cells. So men who have borderline infertility are cautioned against using THC, as this could prevent reduced success of the intended pregnancies. Cannabis and driving. So patients should wait 3 to 4 hours after inhaling cannabis to drive, at least 6 hours after ingesting it, and at least 8 hours after feeling euphoric. Another monitoring parameter for healthcare professionals is cannabis use disorder. Cannabis use disorder is usually identified by patients who are trying to frequently increase their dose of cannabis or change their regimen. If they're starting to crave cannabis and they only want dry cannabis with high THC contents, they might misuse other substances and have poor functioning. They might not be able to fulfill their home, work, or school duties, or perhaps consume cannabis in a physically hazardous environment. They might be missing their follow-ups with their practitioner, and their family and friends might start to get concerned about their well-being. The treatment for cannabis use disorder is mainly withdrawal symptom management, so things like sleep hygiene and symptomatic relief of headaches, irritability, and restlessness. Motivational therapy and cognitive behavioral therapy has been useful as well in the long term. Moving on to patient barriers for medical cannabis, I'm going to start with choosing a licensed producer or an LP. And that is probably one of the biggest barriers, as it's the first step and it's challenging to do. Also for healthcare professionals as well as the patients, understanding the forms and paperwork required. I just want to show you a video of what it was like for me to navigate the Health Canada website. I'm doing this on my phone and recording my screen as I'm going, so I just want to show you what it's like. I Googled Medical Cannabis Canada, and about halfway down the page, I was able to find the link to the Health Canada website. And then when we get to the first page, the first option is getting cannabis for medical purposes. I just wanted to show you what the other options were on that page for completedness sake. However, the important one here is going to be getting cannabis for medical purposes. So when we're scrolling on accessing cannabis for medical purposes, we see the option to get cannabis from a licensed producer, and that's essentially the first thing we want to do. We come to a page that provides us a list of licensed producers, hopefully making it easier for us to decide who our licensed producer should be. Again, we scroll down, there is quite a bit of information on your healthcare practitioner, registering, possessing cannabis, various topics that are important to understand, but not so straightforward when trying to figure out who your licensed producer should be. So we finally find the link to licensed producer. And that takes us to a dead end. So now we got to go back. And the next option is providing your original medical document. So we try that one. And as we scroll down this page, there's an option there to download the form. That is the form that prescribers must fill out from Health Canada. And again, as we keep scrolling, we're looking essentially for a list of licensed producers. So now that we're here on the page of license holders, it talks again about materials for personal or designated production, wholesalers, those who are registered, and more about federal license holders. There are other links on this page, but none of them really seem relevant. When we get to the bottom, we see a full table of license holders. It tells us what they do, what options they have, and maybe some sort of contact information. Getting to this table is a little bit, it's like navigating in and out. And then when you get to this table, a lot of these companies are numbered companies, and a lot of them don't have contact information. So At the end of this, it's still hard to know which licensed producer a patient should sign up with. So let's say a patient does choose a licensed producer, whether it's from a suggestion from their healthcare practitioner or a family member. Let's say that they finally are able to choose somebody they'd like to work with. Once the forms are submitted, the LP will call the patient back and discuss how the process works. Patients can only get a 30-day supply at a time, and all of these items must be shipped. For some LPs, there are shipping fees. One of the examples I saw that was that anything over $99 would be free, and anything under $99 would be $15 as a flat fee. And this is something that would be charged to them every month. Private plans don't always pay for medical cannabis. However, this is starting to change. I know that Veterans Affairs is starting to approve medical cannabis for certain patients. Also, private plans will add medical cannabis for extra fees and things like that. Also, it's important to note that LPs do have programs available. So they have compassion programs for low-income patients. And I've seen discount promotions for essential workers and different options like that. Medical cannabis is one of the only medications in Canada that is taxed. So GST, PST, or HST, depending on your province, as well as an excise tax. So when we think back to that graph I showed in the beginning, those were the prices without taxes and shipping fees and things like that. So you can see how the price of medical cannabis might be a barrier for patients. Like I said, I work in a geriatric community, and it is a retirement community where a lot of my patients live away from their family. These patients don't always have a computer at home, and those that do might not have the internet. And a lot of them do have smartphones or tablets, but they're not so proficient at navigating through the internet in general. So there really is nobody at home to help them. So the fact that they have to log on to the computer to get the information that they need about medical cannabis is a barrier for them. Also, a lot of my patients have difficulty hearing. So when they get these phone calls from the LPs, they don't fully understand the conversation because they can't hear well. Also, there's a lot of new terminology in medical cannabis, and it's something we're all learning as we're going along. The packaging is almost impossible to open. I don't know how many people today have tried opening an edibles package from a retail cannabis store, but I can't open it for the life of me. I'm always using scissors or a knife, and at this point, I do have strong, healthy hands, and I can't get it open. So just imagine how it would be for a patient with something like rheumatoid arthritis. And finally, another barrier to accessing medical cannabis is that patients might just feel that it's easier to go to a retail cannabis store in the community. Those products are licensed, they are Health Canada approved, and they can physically go in and see what they want to get before actually getting it. Finally, the pharmacist barriers. Basically, I feel like there's a lack of education. I have searched high and low for accredited courses in medical cannabis specifically, and they are far and few between. There are a lot of programs out there that are disguised as accredited programs or some sort of certification program, but when you look into it a little bit deeper, they're not actually approved by an academic body. Next, it's ensuring that patients feel safe to discuss cannabis use. I know a lot of my patients are still hesitant to tell me that they're using cannabis. And every time I do a medication review, I do ask, do you use cannabis in any form? And patients normally say no. And then I rephrase it and say, do you use CBD products? And a lot of patients will say yes. So that leads me into patient education. Patients may not realize that the cannabis that they're using is a medication, and it can cause implications in terms of drug interactions and side effects with their other medications and health conditions. So we need to be able to educate our patients. Knowing how to access medical cannabis, even on that video as a healthcare professional, the first time I tried accessing medical cannabis or trying to figure out how to get that access for a patient, it was really confusing. I had to take a lot of steps. There was no linear outline of how to do it or where to go, and it did take some time. Next, we need to check in with ourselves. How do we feel about using medical cannabis or recreational cannabis? Are we treating it the same way we treat other medications? Do we still have misconceptions about it? It's important for us as healthcare professionals to reevaluate how we feel about this and ensure that we are not discriminating against those that use cannabis for medical purposes. And finally, there are several consultation services out there where physicians are employed and prescribe medical cannabis. However, I'm finding that the actual counseling of using medical cannabis is passed off to non-pharmacists or non-healthcare professionals. So usually these people are experts in cannabis specifically, but they don't have a medical background of any kind. And now they're counseling on dosing, side effects, what to expect, when to check in. They don't know much about interactions with their other medications, so that often goes missed. So I think a pharmacist barrier specifically is that we are being cut out of the medical cannabis process. And that doesn't really make sense because we are the last line of defense in terms of every other prescription medication out there. This industry is still in its infancy. It's still evolving and changing, and it's going to be interesting to see where it goes, but I definitely feel like there is a space for pharmacists in this platform. And I think as that starts to become more evident, there will be more education available to pharmacists, and that will help alleviate some of the barriers and help motivate pharmacists to become educated in medical cannabis. Thank you.
Awesome. Thank you. Thank you, Isha. That was a very informative presentation. There was a lot of great information for those considering medical cannabis use. I know I personally learned a lot today, and I'm sure our participants greatly appreciate some of the voice that you offered. So thank you so much. A reminder that if you have any questions for any of our panelists today, to please write them in the Q&A box. So just a little reminder. So next, our next speaker is Dr. Alia Norman. As mentioned, Dr. Norman has been the lead physician at the Newfoundland Cannabis Clinic since 2016. Cannabis is a nationwide network of cannabis clinics that work to educate and treat patients using cannabinoid therapy. She currently works at the clinic full-time, seeing patients with a wide variety of conditions from chronic pain, autoimmune disorders, epilepsy, anxiety, insomnia, PTSD, and cancer. During her time with Cannabis, she has seen over 5,000 medical cannabis patients. Dr. Norman completed medical school in 2001 and went on to do radiation oncology residency in 2006 at the University of Manitoba. She worked as a physician mentor for doctors authorizing medical cannabis from 2018 to 2020 and has been a radiation oncologist in Newfoundland for 8 years. Welcome, Dr. Norman, and if you'd like to begin your presentation.
Thank you. Okay, so I'll start with the disclosure slide. I receive clinic support and speakers fees from Cannabis, and there is an association with Aleafia and Emblem. I certainly would have a much harder time without my my excellent staff. So I appreciate that. I've previously worked as a physician mentor and a speaker with Canopy, and I'm currently recruiting patients for the Cannabis by Shoppers Medical Cannabis Real World Evidence Study. I do not receive financial remuneration for that. So my objective today is that you'll be able to distinguish between THC, CBD, and Nabilone, and where there's overlap, I may skip out a couple of slides. I want you to be able to list the 5 key targets of the body's own endocannabinoid system, relate the biology of that system to potential effects on pain, cancer, and PTSD, and identify some of the limitations to current evidence on efficacy. So detailed information is available on CBD from the Epidiolex drug monograph and the World Health Organization's 2018 review of CBD. CBD has minimal impairment and can be medically useful for seizures, anxiety, inflammation. I certainly use it a lot for pain, but in the acute pain studies, it's limited in its efficacy alone. Most of the CBD oil in Canada contains other cannabinoids, including a trace amount of THC. And that may be giving the different results as a result of the entourage effect. And some interesting early studies looking at it for addiction and reducing cued cravings. It's well tolerated, and the dose can range from 10 to 40 milligrams twice a day, which is sort of my usual dose range, or more than 1,000 milligrams in the purified Epidiolex studies. It does cause dry mouth. It relaxes the gastroesophageal sphincter. It can trigger diarrhea or headache. It can make people slightly sleepy or interfere with sleep. And drug interactions, appetite suppression, and LFT elevation are seen at higher doses. THC is the psychoactive component, and most of these side effects will be no surprise. The munchies, red eyes, which is actually peripheral vasodilation and can result in a drop in blood pressure or an increase in heart rate, and rarely syncope. A dry mouth, feelings of impairment. But unlike alcohol, it's also involved in sensory intensification. And people also may become fixated on either particular sensory experiences or thoughts. Most people find THC relaxing, at least at moderate doses, but about 10% of people will experience increased anxiety. Hallucinations and true paranoia are rare, but can be extremely distressing. And people with psychosis history may experience increase in their symptoms outside of the time that they're using cannabis. And there's an odd side effect called cannabis-induced cyclic hyperemesis, where patients will develop periodic intense vomiting and abdominal pain, somewhat relieved by hot showers. But the actual test for this is 2 months of cannabis abstinence. Cannabis use disorder occurs similar numbers to benzodiazepines. It's more likely to be linked to inhaled and those with a mental health or addictions history. Patients will often say there's no cannabis withdrawal, but that's because it is stored in the fat tissues, and so the withdrawal actually occurs quite late, and it makes it harder to identify. If cannabis makes you hungry, happy, and sleepy, the withdrawal is basically the opposite. And it's a process of resetting the body's endocannabinoid system. But you don't have to get high to get help from cannabinoids. So first of all, there's dosing. We can also combine THC and CBD to offer maybe possibly more pain relief and less side effects. And the entourage may reduce the side effects. This has been clearly demonstrated with respect to anxiety and psychosis. Less clear as to whether it affects impairment. And start low and go slow for the THC. I often find, however, that people will underdose CBD when they're doing it without directions. So it's important to not just take a drop. So tolerance builds up because the cell receptors, CB1 and CB2, decrease in number with repeated exposure to too much cannabis, and also are internalized in the cells. Tolerance can start to disappear after 2 to 3 days abstinence. There's an excellent set of videos on resensitization or decreasing tolerance available at healer.com. There are some benefits to tolerance in terms of less side effects. So one of the questions that's been asked is, does medical daily use of cannabis impair driving? In studies where patients are allowed to take their medical cannabis up for the month up until they're doing their testing, and are dosing in the range of less than 10 milligrams a day of THC, this does not appear to be as much of an issue as acute exposure. THC has multiple medical benefits. It can reduce overactive nerve firing and as a result, less muscle spasm and spasticity, some reduction in inflammation. Can focus the attention elsewhere, which a lot of my patients who are trying to get off other medications, they'll say, well, it just takes my mind off of it, but that's allowing them to improve their function. It may be opioid sparing. It's clearly an appetite stimulant and anti-nauseant. It's involved in sleep and relaxation, memory and nightmare suppression, and THC works in very small amounts. So typically dosing 1 to 10 milligrams, which decreases the chances of drug interactions. The term medical cannabis is a sort of a misnomer. The correct phrase is cannabis for medical purposes. And cannabis can range from very low THC to very high THC, and medical use may use either. So it's cannabis has become typically much stronger in terms of THC and much lower in terms of CBD than it did back in the day. There are recommendations available based on a consensus process for those who are looking for reference on dosing and cautions. And I start the CBD at 10 to 40 milligrams twice a day. I go to once a day dosing if it interferes with sleep. And depending on the patient, add in the THC after that. If your patient says, you know, I took the cannabis oil and you just take a half a grain of rice, they're talking about a super concentrate. These are not licensed products and they are very hard to dose correctly. In terms of pharmacokinetics, inhaled cannabis reaches a peak effect within minutes, and the majority of the effect is resolved after an hour, with return to normal baseline function at appropriate doses within 4 hours. The first metabolite is still psychoactive. The metabolite that's tested in the urine is not psychoactive. Oral cannabis, obviously, slower onset, longer duration of action. THC and Nabilone, this was covered earlier. Nabilone has a different side effect profile in terms of the psychoactivity. Patients who are cannabinoid naive may find memory and attention impairment at anywhere between 0.5 and 3 milligrams. Patients who are chronic cannabis heavy smokers may find that Nabilone actually makes them feel more flat than taking nothing at 2 milligrams. But does have a similar effect to 10 to 20 milligrams of THC if the dose is increased up to 6 to 8 milligrams, which we would not typically use. There are other cannabinoids in the plant, and the interest in the research side of these is evolving. CBG is the first compound manufactured by the plant, and then that's made into THCA, the acidic form, and CBDA, and all of those do have activity at multiple receptors. Raw cannabis is less psychoactive and more anti-inflammatory, but more challenging to dose. And heat decarboxylates them into THC and CBD, and then they stay there. Your body's endocannabinoid system consists of ligands and receptors. THC, CBD, and Nabilone are exogenous ligands, and the endocannabinoids, 2-AG and anandamide, are the ones manufactured in your body when and where you need them. The jobs of your body's endocannabinoid system are eat, sleep, relax, repair, forget, and balance. Or more scientifically, it's a global homeostasis regulator. And it's involved in an incredible variety of processes in the body. Everything from neural development, which continues on into adulthood in the form of synaptic plasticity and memory, to immune modulation. Generally, cannabinoids have an anti-inflammatory but not immunosuppressive effect, with some exceptions. It has effects in the gut, in the mitochondria, in bone development and bone turnover, in pain, in mental health, in psychiatric disease, and in several processes involved in cancer, apoptosis, neovascularization, and it's an mTOR and ERK inhibitor. Because this is a homeostasis regulator, you can get a different response based on dose and a different response based on the patient's baseline state. So in a rheumatoid arthritis, it may decrease immune activity, and in effective wound healing, it may increase immune function, decrease or increase nerve firing, and increase or decrease cell death. As a result, we talk about a biphasic response. In other words, a higher dose is not going to give you a better outcome. The optimal dose, however, is individual to the patient and the condition. The endocannabinoid receptors, the best known ones are the CB1 in the brain and peripheral nerve cells, when that responds to THC and analogs. The CB2 receptors on the immune cells, which respond to THC. The GPR55, which is kind of gives you the reverse of what we commonly think of as the cannabis effects. PPAR gamma and alpha serotonin receptors, and the TRPV1 receptor, which is why CBD may be useful for burning pain, even though it's not active at CB1. And we are still learning that this These products are active at a wide variety of receptors, and they may modify how those receptors respond to other ligands. The first thing that we learned about the way THC has an effect, or anandamide, is as a brake on nerve firing. So after a nerve fires, it releases endocannabinoids into the synaptic cleft, and these in turn will travel backwards and reduce the likelihood that the nerve will fire again. But we're now coming to understand that there are multiple additional molecular targets, and these are involved in neuroplasticity and cell survival. Cannabis has been used by patients medically for longer than pharmacology has been a formal discipline. And I, in my clinic, have seen individuals benefit for a huge variety of conditions. I'm just going to leave that up for a minute. However, our clinical trial evidence is quite limited. And so these are the products and the conditions for which we have clinical trial evidence. Our strongest clinical trial evidence is for refractory epilepsy syndromes and for chemotherapy-induced nausea. And this was the Lennox-Gastaut trial. And there was a quite a significant improvement in the median seizure frequency. There have been some interesting negative trials. NABIXIMOLs were tried in cancer pain, didn't reach the target endpoint of responder rate. They didn't try to reduce narcotics, so we don't know if it was opioid sparing. Very low dose THC for cancer anorexia performed exactly the same as placebo, with both groups responding 70% of the time. It's challenging to make a THC placebo because you have to keep the dose basically less than the psychoactive dose. So I tell patients that that is one place where a little bit of pie actually makes the difference, since the munchies seems to be associated with that level of THC. And low-dose CBD for Crohn's was also a failure. The number of trials for inhaled cannabis is quite small. In 2015, when they did this review, there was only a total of 178 participants. It suggested for neuropathic pain, a number needed to treat of about 3, but these numbers are so small, it's hard to put too much stock behind them. And there was a comprehensive review of cannabinoids for pain published in 2018. And it indicated that overall a 30% reduction in pain was seen in about 30% of patients and 25% for placebo, with the number needed to treat of 24. However, this seems to be very different than our experience in the clinic. And some of the reasons is that there were no trials of CBD alone. If you're going to do a placebo-controlled trial with THC, you have to keep your dosing below the psychoactive level. There were no trials other than Nabilone for fibromyalgia, which is actually one of my favorite things to treat. Some of the products were good quality and some of them were terrible. And conversely, in the clinic, I'm seeing a pre-selected population. So if people try it and it doesn't work, then they are less likely to come to my clinic. And there's clearly a placebo effect which is very much enhanced by the positive reputation of cannabis. In general, the trial benefits have been modest on average, but if you try any treatment in thousands of patients, some are going to do really well. I see about 5 to 10% of patients with really impressive responses. So I wanted to share some data from Israel in their fibromyalgia patients. This has made enough difference in fibromyalgia that it's actually been theorized that fibromyalgia may in some cases be a endocannabinoid deficient syndrome. So they looked at 367 patients with 211 of them completing the questionnaires. And this was the pain out of 10 at the start, with 103 patients reporting 10 out of 10 pain, and by the end, only 3 patients. So you can see the shift from the red to the blue. A similar shift in quality of life from very bad to neither good nor bad up to very good. 73% improved their sleep, and 13% their sleep problems disappeared. There was significant numbers improved in depression. And similarly, using it in cancer, we'll talk about both symptom use and effects on the tumor itself. So for symptom use, similar study out of Israel, larger number of patients, almost 3,000, 60% of them completed the surveys. Cancer patients typically have a large number of different symptoms. And in medical practice, cannabis offers the opportunity to reduce multiple medications because of its wide-ranging physiological processes. There's also a lot of cannabis to choose from, and patients will often use a combination of a sleepier indica or a less sleepy sativa and CBD. At 1 month follow-up, 82% of people going on this program were continuing their cannabis. And they would rated the general effects of cannabis on your condition, with 2/3 reporting significant improvement at 1 month. By 6 months, this was down to 51%. But this was the chart that I find really interesting. The number we're reporting at 8 to 10 out of 10 pain dropped from 52 to 5. Improvements in nausea, sleep, anxiety, depression were in the 80s to 90s. Decreased medication in 1/3, and stopping opioids in 1/3. And again, we see the shift in quality of life. However, with this population, I think it's really important to understand that there's also what I would call the bell ringer effect. So when you finish your chemotherapy, you get to ring the bell to announce that another person is out the door. So if you finish your chemo, your quality of life is going to improve. If you die, then the people with some of the worst quality of life will not be answering the questionnaires. And so, this has to be taken with a bit of grain of salt. There's lots of patients who are seeking cannabis as an alternative therapy against their cancer. But the answer about the effect of cannabis on cancer is not straightforward. Some of the strongest effects are seen in brain tumors. And this was a case of a child with a very aggressive glioma occupying about a quarter of his brain. The parents opted for palliation, which is a very reasonable choice in this situation. But they also started putting cannabis oil on his soother. 3 years later, the tumor is basically almost undetectable, and the child is now school-aged and functioning well. And it was shown that spontaneous involution of low-grade gliomas was associated with pathology that was high in the cannabinoid receptor, CNR1. Cannabis can also interact with treatment. So we see here, this is a mouse model of an implanted brain tumor. And the tumors grew a little bit less on cannabinoids, a little bit less on a small amount of radiation, but when you combine the two, there was a marked decrease in tumor growth. This is a caution for me because patients using cannabis during their radiation, we don't know what the impact is on either short or long-term effects. Short-term patients are reporting that they're doing pretty well, but they may be treating the symptoms of the side effects as opposed to changing the biology. And long-term, we have no data. One of the questions that I've asked is, why do cannabinoids seem to kill cancer cells at fairly high rates in so many lab-based studies, and yet the toxicity on normal cancers, on normal human cells, is pretty minimal? Well, one of the differences between a cancer cell and most tumor cells has to do with the chemistry. So we talked about mTOR and ERK, and those have been clearly demonstrated to be involved. There's also an inhibitor of DNA binding that's involved in many of the processes of cancer, and high levels of ID are found in many stem cells and cancers. And the CBD interacts with these cells much differently than it does when that protein is not upregulated. And it's involved in blood vessel formation, cell migration, cell cycle, apoptosis, proliferation, and invasion. There have been only 2 clinical trials of cannabinoids as anti-cancer agents that have been published. There's a third that was in abstract form, and so I'll just present one here. So this was with NABIXIMOLs up to 12 sprays a day in patients with recurrent aggressive glioblastoma who are also receiving chemotherapy. And the numbers in this trial are extremely small. I was quite impressed by the difference in the survival curves, even with the small numbers. Less impressed when it was pointed out that 2 patients died within the first 40 days. And if you take them out, then there's a very small gap between these graphs. I was also very disappointed when it was finally published several years later that they don't have follow-up on many of the patients at the tail end of the survival curve. This is an oncology nurse that I follow her work, and she works with patients who've chosen to go with the very high dose of THC and CBD as an anti-cancer agent. What she found was that a large number of patients taking high-dose THC demonstrated faster tumor growth within 6 to 8 weeks. And if you reduced the amount of THC, then the tumor growth slowed. There were also about another 20% of patients who showed tumor response. And significant responses were seen with CBD, especially in conjunction with chemotherapy. Well, what about the patient who doesn't have any visible cancer? Well, one of the mechanisms of cannabinoids that's quite concerning is demonstrated here, which is the immunomodulation. So if your immune system is keeping those few escaped cancer cells in check, and you calm down the immune system, even to normal levels, you may be doing harm. So in this study, mice that have no immune system, which are typically what we use for research in cancer, their tumors grew at approximately the same rate, whether they were exposed to THC or not. And that's actually the second line. However, if you gave a mouse cancer, you could demonstrate that the THC was actually causing the tumors to grow as if the mouse was immunosuppressed. And you could crush up the spleens and transfer them to a new mouse, and you would actually see this pro-cancer effect transferred to the new mouse. And we see this idea clinically with a drug, a type of immunotherapy called anti-PD-L1 immunotherapy, which basically helps the immune system to find cancer cells that are hiding. And so patients who use these medications along with cannabis, they drop their response rate from 37% to 15%. This is a single study at the time. There was no statistically significant impact on overall survival or progression-free survival, but the study numbers were small. So I look at it, cannabis in cancer may be a balance between pro and anti-cancer effects. By the way, patients who use cannabis, or people who use cannabis, have neither higher nor lower rates of cancer initially. I think this is an area where clinical trials are critically needed. You can't answer the question, what would have happened if I did the opposite thing? And in my opinion, I avoid cancer cannabis use in curative cases and definitely avoid it with the anti-PD-L1 immunotherapy. In terms of cannabis and mental health, as I said, it may trigger anxiety in about 10%. May also help people to feel relaxed in the moment, but reduce the body's sensitivity to its own endocannabinoids and may prompt more anxiety between uses. Patients with cannabis use disorder reducing their cannabis use may see improvements in anxiety and depression. And cannabis use in teens may slow down the natural improvements in moods that come with maturation. The number of patients involved in trials has been extremely small. The mechanisms are there and they make sense, and we've got preclinical data to suggest that it's effective. There's no significant biphasic response for anxiety, which is reassuring, and doses have been tried anywhere from 5 to 800 milligrams. I find that CBD is better at preventing than relieving anxiety, and it may reduce anxiety responses over time. Cannabis-induced psychosis is rare, but a terrible side effect when it's seen. It occurs in about 1 in 10,000 users. Early onset THC use is associated with onset of schizophrenia. And heavy cannabis users were 6 times more likely to have a schizophrenia diagnosis. But the population rates do not fluctuate with cannabis use in the population. So we think it's more a matter of uncovering it. And the prodromal symptoms of psychosis may cause patients to be, or people to be more likely to engage in risk-taking behavior. So it's not clear which is the causative direction. PTSD has gotten a lot of awareness, and cannabis can be involved in all 3 processes of emotional memory. Consolidation, in other words, making memory stronger; retrieval, the ability for the memory to come back either on its own or prompted; and extinction, the ability to not have the memory come back over time. Cannabinoids have been particularly useful in dealing with the nightmares associated with PTSD. And there was a small trial in Canadian soldiers using Nabilone with high rates of elimination of nightmares. An herbal cannabis treatment in PTSD trial was recently completed. It did show a trend towards improved outcomes. However, the placebo effect was excellent, and the stats changed the number of patients who would need to be on the trial from 250 to over 2,000. So essentially, the trial has to be redone. So a lot of patients think that medical cannabis is going to be effective and safer than pharmaceuticals. However, the fact that it is plant-derived does not necessarily have a direct correlation with safety. Thank you.
Thank you, Dr. Norman. I'm sure the audience will agree that was a very enlightening and informative presentation. So thanks so much for that. Recognizing the time.
Sorry.
No, it's all good, all good. That was fantastic. I'm just going to move us along now to our final speaker of today, who is Emily Wadden. Emily is a registered social worker who works with the AIDS Committee of Newfoundland and Labrador and is also currently the program manager of Safe Works Access Program, SWAP, which is Newfoundland and Labrador's needle distribution, harm reduction, and take-home naloxone training and education program. Emily is part of Atlantic and national drug user groups advocating for changes in drug policy in Canada. She is a person with lived experience of using drugs in addition, working hard to educate healthcare practitioners around stigma, discrimination, and language. Welcome, Emily, and I'll now pass the virtual mic over to you.
Perfect. Thank you so much. Appreciate it. So yeah, disclosure, conflicts of interest. I have no real or potential conflicts of interest to disclose. So basically, just quickly, the learning objectives for myself, just honestly recognizing cannabis as a valid substitution for drugs and substances. Identify some of the barriers and challenges that, for individuals related to accessing medical cannabis, and acknowledge and recognize the lack of policies and procedures that, allow individuals to use medical cannabis. Oh, skipped ahead of myself. So harm reduction in medical cannabis. So harm reduction, it's quite literally a strategy basically for people to reduce the harms associated with various, activities, behaviors, and things. For this presentation, I'm going to talk about harm reduction just strictly in relation to medical cannabis and, slightly in relation to other drugs like alcohol, opioids, stimulants, etc. While some of what I'm going to talk about includes, anecdotal evidence or information, it is supported by the research and literature on medical cannabis, which in a lot of ways can be, which in a lot of ways can be, oh my goodness, I am uncertain of technology. Okay, sorry about that. Anyways, so like I was saying, the research, it is somewhat limited. Like I believe it was, I'm not sure if it was, I think Isha said, you can find a lot of research that doesn't support the use of cannabis during pregnancy. However, you can also find research that also suggests that there's not a lot of harms either. So I found with my own just kind of looking at cannabis research, there's almost research that you can kind of find a conclusion for what you want to find a conclusion for, unfortunately. So, in general, medical cannabis absolutely has been at the very least explored for substitution purposes for many types of drugs. There are studies where individuals report lower levels of drinking, using prescription drugs, tobacco, stimulants, and even some street stuff like heroin, for example. So individuals prescribed medical cannabis also report purchasing cannabis from other sources, such as, retail stores or even their buddy on the street. We're going to get into talking a little bit about that, but as Isha also showed us, some of the prices are just not comparable. $32 versus $105, it's a no-brainer, especially if insurance and such is not able to cover that. So one of the reasons that, it's sort of hard for folks, well, one second. So I guess for starters, as a social worker, I work primarily with people who use drugs, many of whom have, been incarcerated, they've been homeless, they've experienced or are experiencing, trauma, violence, abuse, poverty, etc. And, many of them, unfortunately, like many others right now in Newfoundland, don't have any type of access to family doctor or any type of primary healthcare physician. So, when addiction and poverty and trauma are ruling someone's life, unfortunately, physical and mental health typically take a back seat. Many of the folks I work with, they've had family doctors or any connection to the system maybe in the past, but perhaps they were incarcerated or, had a significant life event and were disconnected. Or maybe they're new to the province and have no idea where to start. We also support a lot of people who are new to the province, and it seems to be more and more lately. So whatever the case may be, this leaves individuals, with large gaps maybe in their health information and many times no access to information within the health systems. Our health system is constantly changing. It's really hard to keep up. So, many people don't know where to start. Should they even want to consider using medical cannabis? And without support, this can be pretty overwhelming and seemingly impossible. There are definitely fears around seeing, formal or super professional, healthcare practitioners, just because many folks, people who use drugs, people who have a history of addiction, they've been accused of seeking drugs for the sake of getting high from people. And it's really not easy to meet new people and open up to new healthcare providers when, you've been or felt misunderstood or mistreated in the past. Another one of the challenges associated with medical cannabis is financial limitations. Even with programs and services that offer, self-referrals, many of the folks I've worked with, they don't even have valid pieces of ID. They need a government issued ID, they need an MCP, and I believe for government there is a fee to pay belongings have been lost, stolen, or left elsewhere, and they can't get it back, or they don't know where it is. So even just getting some of these simple pieces of information to even consider enrolling in such a program, it's hard. IDs cost money, let alone the required transportation and or permanent mailing address required to complete some of these forms. Not having a permanent address or even cell phone access or minutes to communicate as well, just to even communicate for appointments, is super challenging. And, you know, all of these challenges can increase if folks are required, which they are, to order their products online. So I just wanted to, I guess, kind of point out some of the main differences between, I guess, official medical cannabis that's actually prescribed, monitored, and obtained from licensed producers versus, say, street cannabis that's maybe being used medicinally and or in the place of drugs, because that's what I see most often. I haven't met very many people that, you know, have an actual referral and prescription and this and that. But I have met many, many people and know many people who absolutely use it for health purposes. Their, you know, the rest of their healthcare team is very well aware of it. It's talked about consistently in their treatment plans. So that's a really, I guess, common situation. So I guess for me, the most common reason for cannabis substitution, in my experience, have either been for opioids to manage physical pain, or in the place of someone's preferred drug of choice, like cocaine, maybe some opioids like Dilaudid, morphine, etc. And yeah, personally, I fall into the category of also using opioids, not using opioids. I fall into the category of using cannabis products that I purchase online from a retail location to deter myself from buying opioids and stimulants on the street. It's not foolproof by any means, and it's absolutely useful as kind of like a protective factor in a way. So as you might assume, for medical cannabis, there's obviously, you know, a formal referral process, prescription process, selection process, receiving process. So there's quite a bit. You know, there are predetermined hours of operation to consider, like, you know, the licensed producers, they're not available 24/7 to call and ask questions. And this, that, the other thing, neither are the post office. And there's also maximum amount of products available in a given time period. So that's monthly, as we know. And there's also, in theory, a maximum per day, which I believe was 5 grams. Some private insurance companies, as we're learning, are beginning to cover medical cannabis. And like Isha also mentioned, there are some discounts instead of recreational cannabis. However, ultimately, I mean, you know, if something in the store can be purchased for $30 versus, you know, $100, and even the $100 is given, say, a 50% discount, it's still $50 plus shipping and maybe the licensing producer's fee or something, right? So it's unfortunately not really cheaper. So, and on the other side, obviously, we have cannabis that you can buy on the street. I didn't really include or feel the need to include something for retail cannabis because I wanted to kind of show the two differences. And honestly, retail cannabis, while some characteristics like, you know, there's ordering or there's business hours, you can't get it 24/7. They obviously only have certain products with limited THC, this and that. I would say that, you know, many of the, I guess, convenience factors for, you know, recreational cannabis kind of fall more on the street cannabis side. So obviously for street cannabis, there's no formal referral process. Hours of operation definitely vary. And while they might not always be consistent or as consistent, especially as a dispensary or retail store, the overall flexibility in the buying process, that's a huge draw. Many of the folks I work with, you know, they aren't able really to plan ahead when it comes to maybe obtaining their substance or hoping that they can get their drug of choice and not have to settle for something else. Just because oftentimes they might not know where their next meal is coming from or where they're sleeping that night. So, you know, planning ahead in a formal process and ordering something every 30 days, having to have a mailing address, these things are a little more complex. You know, the transient nature of many of the individuals I work with, it doesn't always align with the formal structure of a rule-based system. And of course, cost is a major barrier. You know, while we've, you know, already touched on the not so obvious costs associated with medical cannabis, the obvious cost of the actual product itself, it's often unrealistic for low-income individuals, even at discounted rates. Street cannabis prices, on the other hand, at least right now in Newfoundland, in this current COVID climate, the prices are quite low. You know, cannabis purchased in stores can be anywhere from $5, $10 to $15 more expensive per gram than cannabis purchased on the street. You know, many people years before cannabis became legal, they already had pre-existing relationships with cannabis dealers. So between that and the ability to get a lot more product for the same price and the flexibility, of course, with the option for delivery, because many dealers have cars, why would folks seek out, you know, official or more formal routes of obtaining cannabis for medical use when they can kind of do it this way? So, additionally, individual cannabis dealers can also accept any type of payment that they choose. And this one is maybe one of the biggest things. This can be super helpful and useful for individuals that have little or no money, because they have the ability to, you know, barter for their cannabis with goods and services, not just money. Other challenges related to kind of medical cannabis, just on a broader scale or in general, include the legal system. Many people are subjected to court orders attempting to limit their use of drugs and random drug tests throughout probation and or parole. You know, it would also, we've recently introduced drug treatment court, and it would be unlikely that the individuals involved in that are also permitted to use medical cannabis, as abstinence is typically synonymous with these programs, unfortunately. And next we have social services and programming. And, you know, while many of these programs and services absolutely do not require sobriety, structured programs, or maybe say like GED programs or education programs, you know, they're not going to go out of their way to accommodate, you know, smoke breaks or edible breaks, etc. And unfortunately, even though it's legal, you know, people don't love standing next to somebody that might stink of cannabis if smoking is their preferred method. It's not ideal. It's obvious. People sometimes make a big deal out of it. And, you know, even large quantities of edibles, like you don't want to bring that anywhere with you, because, you know, typically we don't really have our other medications on display. So unless you want to go off into the bathroom or something and eat it, like it's not all that convenient. Next, we have employers. So many employers, and including, you know, entry-level employers, in some cases, they require drug testing. I don't really understand this. And it's unfortunately ultimately pushed a whole lot of pot smokers, to become cocaine sniffers, because that, you know, only lasts in a urine test in a way smaller period of time. So that's unfortunately what's occurred. Many employers view cannabis as impairment in the same way as alcohol impairment. And while those being legally prescribed, certain anxiety medications, say example like benzodiazepines, known to have sedating effects, are able to work in these same jobs. You know, medical cannabis, not always. Stigma and discrimination certainly play a role in this logic and reasoning, and many workplaces honestly just don't have policies and procedures created to accommodate employees prescribed medical cannabis, especially if it's being smoked. Businesses and organizational, liability insurance may also create challenges for medical cannabis users, again, citing active impairment should an accident or workplace injury occur. Finally, there are unfortunately limitations as well for using medical cannabis while, say, as a patient in a hospital. To my knowledge, you should not expect to receive your medical cannabis while recovering from surgery or something of the like, as, hospitals don't have their own safe supply of cannabis per patient, and bringing medications from home while in the hospital is typically not something that is allowed or happens. This, in some cases, and in a lot of cases, based on, what I see from using all types of drugs, it deters individuals from even going to the hospital. So what could have been, maybe a small infection treatable with antibiotics is now a massive infection where you need, many, many hours of IV antibiotics. So, it deters folks from going to the hospital, and because they fear ultimately going without their daily medication that they need to function physically or mentally. And I've been in the hospital too, and, it's anxiety provoking to have to worry about like where I'm going to get my Suboxone, let alone something like medical cannabis, right? Like Suboxone has been around, it's a well-known course of treatment, and even that I'm partially uncertain about sometimes. And lastly, and this one is kind of a big one, and I'm hopeful that it'll change in the next 5 to 10 years. Being able to, use your prescribed medical cannabis while in an inpatient treatment center, rehab, or say a sober living house or facility, I've yet to see it be allowed anywhere. And this is maybe one of the biggest barriers that I've personally experienced. So, while medications like Nabilone can be prescribed in Canada as a substitute, this is just really largely dependent on the comfort and knowledge levels of the in-house medical team in those places. In my experience, and under one of Canada's largest treatment networks, I was prescribed Nabilone for my anxiety, considering I smoke and still smoke pretty much primarily for that reason. And anxiety wasn't even one of their usual reasons for prescribing it. Isha didn't mention it under one of their off-label prescriptions. And it was pretty much often reserved for folks with medical cannabis prescriptions on the outside who were unable to bring this type of medication in with them. So when I came back to Newfoundland, because this took place in Ontario when I was prescribed this, no one in my healthcare team had ever prescribed this. Some of them hadn't even heard of it, and they were only comfortable re-prescribing it for me in very small doses just because it was initiated elsewhere. So, while I've been on this medication for a few years now, I really can't help but wonder if I ever would have actually been offered it here had I not gone away. And, after being on Nabilone now for, I think, 3-4 years, I also went to treatment again, but this time it was in the States. And while you can take Nabilone across the border, or at least I do, and I haven't had any issues because it's another medication in a pill form, it wasn't available in the treatment center. They couldn't get it from the pharmacy, as it was something that in California or in the States, it was exclusively reserved and prescribed for cancer patients only. And this definitely, it put me in a pretty challenging position, as I wasn't really looking to mess with my medications. And similarly, something that, I forgot to mention that definitely goes well here is the idea of traveling with medical cannabis outside of Canada. It is illegal, and you can be criminalized in the same way. And, obviously, while this can be a problem for many people who enjoy traveling. We have many folks in Newfoundland who spend, 6 months in Florida, 6 months here. So, while it's possible, yes, to purchase cannabis legally in some states, there isn't a universal rule, and medical cannabis doesn't get any exemption in relation to border crossings. So yeah, medical cannabis is absolutely super important and an absolutely underutilized tool, not only in addiction recovery, but just for many people's overall wellness. And although, you know, I spent most of my time highlighting in this presentation the various gaps from just, you know, social workers and social service workers perspective, you know, I have seen this make a world of difference. And yeah, that is all. And I don't know how to exit. Oh, I do.
There you go.
Pass it back to you now, Christina. I'm done with the line.
Hey, no, well done. Thank you, Emily, for your honesty today and for sharing some of your experiences. And like, you know, I really appreciate your insight and your advice and some of your suggestions. So great presentation. Thank you so much. So I'd also like to thank all three of our presenters today and sharing their insight with our audience. I think everybody will probably agree that our goal of bringing together perspectives and insights from three different healthcare disciplines was met today. So three exceptional and educational presentations today. So thank you all again. So we have about 20 minutes. So I'm going to move us into our question and answer component of today's webinar. The first question I have is for all three. There has been some interest in having access to your slides. The recording will be available on CHIRP's website. Are the presenters willing to share copies of slides, or alternatively, do you have good resources that we could recommend for people to use? So
I'm happy to have you post my slides to your website.
perfect.
Yeah, me too.
Yeah, that's no
Emily?
issue.
All right, so yeah, so we can probably send out a copy of the slides to everybody who's interested. Perfect, thank you. The second question again is for all three. What do you think is the best way to address the stigmatization of medical cannabis consumption in your respective professions? So does anyone want to take it? Or maybe Dr. Norman, is there any insight that you'd like to offer to that question?
Well, I certainly think that legalization has made a huge difference. In the senior population, it's definitely become quite the topic.
Yeah.
I think the biggest place that I run into stigma issues is with respect to workplace, and some very odd hard lines about cannabis, including CBD dominant products, and at the same time as admitting that their cocaine has become the drug of choice because of the urine clearance.
Yeah. Perfect. How about you, Aisha? Is there anything that you'd like to add to that question? The best way to address stigmatization.
Yeah, I think that it's all about having conversations and us ourselves being educated as healthcare professionals so that we feel confident to answer questions. A lot of my patients are like, I've never used drugs before. And it's important to explain to them that this isn't the same as using drugs. It's medical cannabis. It's used for medical purposes. On the flip side of that, when I have students come into my pharmacy, I ask them if they have any experience with cannabis education, and they get 1 hour in their respective programs from across the country. And they come into my office and they're also kind of like, I've never used cannabis. I don't know what to do. I don't know what to say. I don't understand the terminology. I don't even know the difference between THC and CBD. So, and these are 3rd and 4th year pharmacy students that come in and have these concerns. So a big part of my precepting is that I do ask them to do a cannabis presentation for me so that they can become familiar enough to have these conversations with their patients.
Oh, perfect. How about you, Emily?
I think definitely the conversations, but also the leading by example that I think we're all doing, and creating those environments where the conversations can happen, and the openness and the honesty. And I mean, I love a direct question, so I would absolutely do the same as Isha and just put it all out on the table.
Yep. Perfect.
And
Thank you.
just one further comment. I found that working in a cannabis clinic that I've had it's opened its doors to having other stigmatized conversations. So patients are much more likely to tell me that they're queer. They're much more likely to tell me that they use other substances. And so it really has changed our conversations. And that's a thing that I would encourage people to ask and be open. And it has changed how I perceive people who use drugs.
So do you think that cannabis used to be the elephant in the room, and once you get that out, that they can give you more information about themselves?
I think it's more that once they know that you are a person that they can talk to about A, then they're more willing to talk about B, C, and D.
Gotcha. Thank you. Our third question came from the audience. I'm wondering about your thoughts on prescribing cannabis in a person with a stable psychotic illness, lower risk use. So anybody want to take that one first, or?
I would.
Sure, absolutely.
So I think that, you know, the level of advice that you need depends on the level of risk for many things. So, you know, if you're a healthy 25-year-old with no mental health history, sure, get your advice from Joe on the street. It's one of the reasons that I like to see cannabis in the pharmacies, because I think pharmacists are great people to identify, hey, you're on an antipsychotic medication. You know, maybe that you need to talk to somebody who knows what they're doing in this. I take a harm reduction approach. So if somebody's already using cannabis, and I can get them switched over to more CBD containing, less inhaled, really open up the discussion. What are you using cannabis for? So if they're using it to block their nightmares, you know, maybe they need to look at nighttime Seroquel or Prazosin or something like that. So, you know, I think one of my roles is to help that discussion in the more complex patients. So I think you have to, I would never initiate THC, Nabilone, or even CBD in somebody with a history of psychosis who is cannabis naive, unless it was really a last option. But I would have no problem authorizing somebody to use a lower risk thing than what they were already using.
Okay, perfect. Thank you. Isha, is there anything that you would like to add to that question?
But I also document the hell out of it.
No, I think Dr. Norman did a great job answering that. Yeah.
Absolutely. How about you, Emily? Is there anything you'd like to add to that question?
Absolutely not. I know nothing about prescribing anything.
Awesome. Thank you. So this is probably going to be our final question. Cost seems to be a major barrier for patients. Are you seeing any movement with insurance providers and their willingness to provide coverage for medical cannabis? So
Yeah, I can take
you
that
could
one.
probably speak to that. Yeah, absolutely.
Yeah. So yeah, there is a movement. Private companies are starting to cover medical cannabis. Usually it's in a tiered system. So if somebody's in a lower tier of their benefit plan, they don't get coverage for medical cannabis. But if they're paying extra fees, there is allowance there for medical cannabis specifically. And like I said, Veterans Affairs is starting to provide coverage for certain patients. So it is starting to move, but I've really only seen that movement in about the last year or so.
Yeah.
Workers' comp varies from province to province. So Newfoundland has a very restrictive, is very restrictive of anything other than Nabilone. But there are other provinces where it's reasonably easy to obtain.
Okay. Right. Oh, I do have one last question. someone from our audience would love to hear more about your opinions on how cannabis can be effectively used as an opioid substitute. So, Dr. Norm, is that something that you can speak to?
I can, but if somebody else wants to start,
I mean, about how it can be used?
How cannabis can be effectively used as an opioid substitute.
Okay, well, I mean, I guess in my experience, the piece I think that is most useful and maybe why there is success. I mean, obviously the two drugs feel widely different. However, so a lot of the, I guess, the habits and the rituals around it are, you know, switching one drug that is super duper, I guess, harmful or can be super duper harmful and result in death. And, you know, changing that again from a harm reduction way to something that, you know, ultimately cannot cause death. Like, yeah, you can get really sick and stuff, and it's cannabis isn't going to kill you. And I think what is particularly successful is just the switching of the habit, focusing it on something else. And that's the piece, that's the success. I mean, you really can't go into it expecting that, you know, it's going to provide you maybe the same relief or the same intensity level of relief and this and that, at least in my experience. However, you know, it is taking an edge off. It's not everything by any means, and it's taking an edge off. And, you know, it definitely is successful for many people at various points. Definitely doesn't work forever. I would caution that in my experience, it doesn't work forever, but yeah.
Perfect. Thanks, Emily.
And I'm actually going to post an article in the chat by Dr. McCallum, who's from Newfoundland, now practicing out in BC, called Practical Strategies Using Medical Cannabis to Reduce the Harms with Long-Term Opioid Use in Chronic Pain. It's a 2021 article.
The anecdotal and the evidence. What more could we offer here?
There you go.
Thanks so much. Do anyone have any additional comments to add, or?
I think one of the things that's important is that cannabinoids do not suppress respiration. Therefore, they're relatively safe to use alongside opioids, so my strategy is basically I start, you know, and I go reasonably cautiously, but I start by adding the cannabinoid in, get the patient more comfortable, reduce their anxiety, improve their sleep, improve their pain, and then start the weaning process rather than trying to do them concurrently.
Perfect, thank you. Well, we got one last late blooming question come in, so I'm going to pose it to you. What counseling or guidance do you provide your patients when it comes to driving, especially if they require regular cannabis dosing? So is there any, like, I think that's in reference to your presentation, Dr. Norman?
Yeah, so I don't restrict driving on CBD dominant products, not one-to-one products, but CBD dominant products, like a 20-to-1. But I do ask that people initiate it when they're not driving, because occasionally we'll see drowsiness or super sensitivity to that little bit of THC. I tell people that the law is you can't drive impaired. It doesn't matter on what, and that includes not sleeping, lack of attention. The evidence suggests that for inhaled cannabis of like, you know, a couple of puffs, 4 hours is fine. Once patients are on a steady dose of THC at night, I do not restrict their next morning impairment if they don't feel that they have any impairment. But if they're in a more safety sensitive situation, or if they already have some deficits or other medications, there's an app called Druid, D-R-U-I-D. And that is a drunk test for your phone. The roadside screening test tests for the active THC, not the inactive metabolite. The blood levels, if you're, say, involved in an accident or have been determined to be impaired, blood levels are based on the breakdown products. So if you drive impaired and you're a regular cannabis user, you will fail that drug screen, but they don't do the drug screen unless you are impaired.
Perfect. Thanks. Thank you. So this is unfortunately all the time that we have for questions today, but it was certainly my pleasure to serve as your moderator today. So I thank CHIRP for that opportunity. And I now invite Dr. Jennifer Donnan, who is a principal investigator with CHIRP, who's going to provide a few closing remarks today. Dr. Donnan?
Thank you so much. Thank you, Christina, and to our three speakers today. You guys were so informative. You left me with so many more questions I wanted to get out today, but I do need to respect people's time, and I'm sure we'll have time to get those questions to you at a later date. But no, thank you all very much. And thank you to all our attendees for coming to our fourth and final Cannabis Crossroads webinar in our series. It's been a really successful series. We've been really excited just to get some education out to the public because we have heard from people that it's desperately needed, and we hope that those topics were useful to people. So for anybody that hasn't heard the previous ones, we have one on access to safe cannabis, cannabis in the workplace, and cannabis in driving. And those can all be found, as well as the recording for this session, on our website, as well as going to our Facebook and Twitter pages. And those handles are at CHIRP, C-A, C-H-E-R-P, C-A.
Jennifer,
yes.
before you go, I just have one more comment.
Yes, go right ahead.
If people are looking for information, if you're a family doctor, you can access me through eConsult. If you are, and I'm fairly easy to get a hold of via email, if people have specific questions, patients can self-refer or be referred by their physician at Cannabo, C-A-N-A-B-O. Just Google it.
Excellent. That's really helpful because I'm sure there's lots of people who are interested in getting access to more information and the advice from you as an expert in this area. So I also wanted to take an opportunity just to thank the many people that went into helping coordinate these events. So Dina, who you heard from at the beginning, she's been working very hard over the last number of months coordinating speakers and all the fine details that go into this. We had some students, Maria and Sandy, as well as our research assistant, another Sandy, who helped get all this work, all these events up and running. I'd also like to thank Conference Services for helping with all the technical side of things, as well as the Conference Fund, who helped fund getting this webinar series organized. And if you are looking for your certificate for the CE, you can just email us at caneval, C-A-N-E-V-A-L, at mun.ca, and we'll get that certificate out to you. So that's approved by the Pharmacist Board, but you can also use it for like self-assigned CEs for other disciplines as well. And I think that is everything from me. But again, thank you all. And yes, have a great day. Enjoy the rest of your day. Take care.
Thanks, guys.
Bye.
Great working with you.
And to John and Josh, I believe, can you put us in the practice session?